Much for joining us today. We're going to get started in one moment. I see a lot of people coming in, but still a lot of people in the lobby. So I want to make sure everybody's inside. We'll get started in about a minute. I think there is like a background blur, Lindsay.
Yeah. Oh, maybe that's what it is.
I keep telling Larry we need like intro music or something here. So, all right, everybody, it is 2 o'clock, at least Central Time. So we'll get started. Hello and welcome to the Rural Health Executive Educational Series. I am Cody Smith, the Director of Rural Partnerships with NRHA Service Corporation, and I'll be your moderator today. And I'm glad you took the time to join us. Before you jump in, just a few notes. Today's session is being recorded, but we'll send that link out later today so you can revisit anything you want to or share it with someone on your team who couldn't make it or anyone that you think would find the information useful. You will also receive a short feedback survey afterward. I know we hate surveys, but it will only take a minute. And it really does help me keep these sessions focused on what's actually useful to rural leaders. So I thank you in advance for filling that out. A couple housekeeping items before we get started. Everyone is muted. This just helps us keep things running smoothly. Presentation will last anywhere from 30 to 45 minutes, and this will leave time for questions. The question panel, however, is already open, so please feel free to drop those questions or comments in there anytime during the presentation. And if something resonates with you, you can also use the reaction feature at the bottom of your panel along the way. We want these sessions to be helpful and practical, so don't hesitate to jump in with your questions. With that, let's meet our speakers. Today we have Cameron Smith, a former hospital leader who helps health systems identify root causes of operational challenges and turn them into measurable improvements. He's led quality, performance improvement, and patient experience initiatives, delivering cost savings, reducing readmissions, and improving safety outcomes. His work focuses on practical data-driven strategies that strengthen performance and long-term sustainability. We also have Lindsay, I'm going to mess it up just because I'm in my head. We also have Lindsay Corcoran. I did it. Corcoran. She's a principal and a strong advocate for sustainability and access in rural healthcare. With decades of experience in healthcare and a background in practice management, Lindsay has worked with rural and community hospitals and clinics across the country to improve operational, clinical, and financial performance. And I do know Lindsay, and I knew I was going to mess it up, but I tried. I apologize. With that, I'm going to go ahead and be quiet. I'll turn it over to our speakers for today's presentation. Thank you, everyone.
All right, thanks, Cody. So welcome, everyone. Thank you for joining today. This webinar is around embracing quality improvement as an organizational strategy. Next slide, Kim. And Cody did a great introduction. So I'm Lindsay Corcoran, principal at Stroudwater, and I'm joined by Cameron Smith, a senior consultant at Stroudwater, and we're happy to be here. Next slide. So some of our learning objectives and what we want to hope to achieve today is really explaining and kind of setting the foundation for why quality improvement should be a strategic importance for an organization, identify practical methods around how we can integrate and tie in our quality goals into our operations and leadership structures of our organization, and start to have a conversation around engaging the engagement of staff and key stakeholders in developing and creating that culture of continuous quality improvement and patient-centered care. And hopefully we'll be able to really provide a great overview for kind of what that looks like, and for you to take some kind of best practices away in a framework for this approach. Next slide. But before we begin, we do have a polling question. So Cody, if you have a moment, if you could just launch that. The first question, we just really want to get a better understanding about how important is quality to your organization's strategic goals for the next several years. Is this something that is included in your overall strategy for your organization, or not included, or maybe it's a priority, maybe it's somewhat a priority? If you could just take a moment and just kind of let us know where you are in that spectrum.
Great, thank you, Lindsay. And I just want to make sure, can you see that on your screen?
Yes, we can.
Okay, wonderful, thank you. So we'll leave this open for a couple more seconds and then I'll share those results. All right, I'll go ahead and share this with you now. Thank you everyone for participating today.
Thank you. Okay, is this being shared right now?
It is.
Okay, great. So it is nice to see that no one selected not included. And, I think a lot of folks, it's showing 61% have said it is a priority. And so we do believe, Cameron, you can go to the next slide, that quality should be a very high priority in terms of your organization's overall strategy. So we're in a changing market, and we're going to kind of lay kind of a foundation about what we're talking about and how do we get here. But I first want to level set and talk about what is healthcare quality. As it's defined by the National Academy of Medicine, it's really about how well our healthcare services improve outcomes and align with what we know works in clinical practices, really setting the foundation for everything that we are targeting or aiming to achieve in healthcare. And quality improvement is really the method and how we get there. So it's more of that structured, systematic approach, focusing on reducing, say, variation. It creates a level of consistency and ultimately really delivers more reliable, predictable outcomes for patients in our organizations. And when we think about improving quality, we look at two components. We look at structure and process. So when you think about structure, it's including everything that we're kind of working on or within our environment, like technology or organizational culture, leadership, physical capital or resources. And then process is really around the training, or basically how that work gets done. And that includes things like knowledge capital, like standing operating procedures, or human capital. And that's really around education and training and how we support our teams for delivering care effectively. And when those two kind of structural, the structure and the process really come together, it creates conditions for better outcomes and how we look at healthcare quality. Next slide. And how it's viewed, how healthcare quality is viewed is very different for anyone who may ask that question to or who you talk to. We can, for patients, it may mean about their healthcare quality may be about their outcomes or their experience. For, a provider, it may be a focus on clinical effectiveness or something along those lines. And so there's differing perspectives of healthcare quality. And I think without the lack of alignment around what is healthcare quality, then organizations often can start to compete on different priorities. There's inconsistent approaches, and really makes it a lot harder for organizations to create that alignment around the importance of quality as a strategic imperative. Next slide, please. So why do we need to focus, and why should we focus on quality today? We're seeing continuous cost rise. And, when we think about quality from a cost containment perspective, looking at efficiencies and so forth as a way to combat quality. Advances in healthcare technology and adoption, certainly we are seeing that as new market competition, new market and folks entering the market. And we really need to keep quality at the forefront as it relates to some of these advancements. We're seeing declines in various hospital inpatient, outpatient volumes and reimbursement. We're seeing a change in the payment system, moving away from that fee-for-service payment system and moving more towards value-based care or population health. And then really just to ask ourselves at the end of the day, why wouldn't we focus on quality today? Next slide. So when I mentioned that transition from the fee-for-service kind of payment system to one of more value-based and population health, is, we define, this is our transition framework for at Stroudwater. This is what we consider our roadmap for that transitioning payment system, in that there are key aspects or elements within each of these kind of transition turns or phases, if you will, and that really help organizations move towards more of that future value-based, population-based payment system. And you can see at the top there in phase 1 of the delivery system is that significant focus on operating efficiencies, quality, and patient engagement. If organizations are not focusing and doing those 3 elements today, then you are already behind in terms of that transitioning payment system. So it is such a critical element as you think about that transitioning payment system and how successful organizations will be as we continue to evolve. Next slide, please. So from a call to action standpoint, we have what hospitals have what's called a quality assurance performance improvement plan. And this is really that a quality assurance performance improvement plan or program is foundational for organizations to make sure that you're delivering high quality, safe care. And when organizations are fully engaged around the hospital's program and plan, they engage in that continuous organizational-wide assessment and improvement. They create this culture of quality and safety, and it's something that's consistently prioritized, really surrounding around the QAPI program and plan for an organization. At the same time, QAPI, conditions of participation deficiencies, are the 3rd most frequently cited of the 24 conditions of participation for Medicare certified facilities. So we still haven't gotten it completely right, and there is work to be done, but that is a mechanism in which we can really start to engage our organizations around and really ground them in creating an effective and aligned kind of quality program for our organization. Next slide. But one question that always comes, or the factor that is always questioned a lot of the times, is the conundrum of quality and finance. And can you have both? And what is that lever? And we do think that you can have both. And a driver of that is around creating patient value. And you can see from the equation, right, is patient value can be an economic driver. And because quality, if you increase the quality, at the same time decreasing the cost and spread that over a population, you create that patient value. And we can utilize that as the vehicle and that economic driver to our organization, connecting that quality and that finance together. Next slide. Interestingly, just tying back to quality as a strategic driver and the strategic value of quality, the NHAQ just released a study in 2025, and it was really around the importance of quality and patient safety and investing in that. And what I loved, what it really showed was quality is not just that feel-good endeavor. For so long, it was the soft side of healthcare. It was, not always, at the forefront of our organization. And now, today, and through some of the results of this study, it can be and should be a financial strategy for an organization. Some of the examples that were in this particular study, they're not all rural hospitals, but I think what the study also highlights is that their efforts and what they did really as they put quality at the forefront, can be applied and very applicable to rural hospitals across the country. Next slide. So where are we as an organization today, or just in general from a national wide perspective? So if you are a critical access hospital, you may be familiar with MBQIP and a global measure around the CA quality infrastructure measure. This is a annual survey that goes out, and some of the results of that survey back in 2024 showed that only 60% of critical access hospitals ensured that quality is an intentional component of the strategic plan. And 56 of the critical access hospitals intentionally build external relationships with patients and partners in the community. And then 69% of the CAs use internal and external data comprehensively and transparency to inform quality improvement. Updates in 2025 show about 66 of the critical access hospitals are meeting the strategic planning measure elements. So, 50, close to half, a little bit more than half of critical access hospitals are really leveraging quality as kind of that strategic imperative. And I think that there is, certainly there's a gap and there's an opportunity for folks to really create that focus there. We did do some internal data collection from organizations around a quality program assessment and understanding what some of the top areas for improvement were for these folks that took our internal assessment. And what trickled to the top was around developing effective methods of data utilization, inclusion of quality and strategic planning, and linking quality to value-based care incentives. Again, so you can see that there's the opportunity around quality in terms of strategic planning and as a strategic imperative. Next slide, Kim.
Yeah, so Lindsay really laid out the kind of where we're at today and what's brought us to kind of this call to action for quality to be seen as more of a strategic lever in most organizational frameworks. And from our work, the next kind of couple of slides are going to lay out what do we see from our time going through hospitals, working with hospitals as an effective framework to where quality is really set up for success and not just as something that's done just as a regulatory check and making sure that, yeah, we've got it, but also as something that is an organizational priority and a strategic priority. And it really revolves for us around three pillars of leadership commitment, an effective infrastructure, and do we have a measurement system in place to realize results, whether they're effective, not effective, or do we need to course correct? And we're going to spend the next couple of minutes walking through what do these various pillars look like? What does it look like for leadership commitment to effectively set up quality? What does a good infrastructure look like from our opinion? And how do we effectively measure quality? So commitment looks in a couple of areas differently depending on the level of the organization that we're looking at. For a board of directors, do we have a board of directors that is engaged in quality improvement? Are they aware of their obligations surrounding quality? One of the questions we typically ask is how often does your board of directors receive an update regarding quality? Do you have a board member that's involved in your quality committee? Do they sign off on your quality plan on a reoccurring basis? And could they speak to quality or some quality program activities if they were asked? So the degree that the board is involved and can speak to things such as engagement, quality out in the market really shows strong commitment from the top to, overall organizational strategy. Of course, super important that the senior leadership team is involved and bought into quality. We want quality to be much more than just somebody who's in an office with a binder waiting for the next survey to come in. It's more that do we have a CEO, a CNO, a CFO who all see quality, patient experience, and engagement with the community as something to be sought after and to strategically and as a strategic priority. To what degree are we proactively engaging with our patients and not just waiting for patients to come to us? So reactive versus proactive healthcare is also a factor of engagement and quality. Does our senior team believe that? Are we rounding? Are we talking with staff about what did they see as opportunities for improvement within the organization? And then have we adequately set up the quality program for success? Very often quality is just put aside, it's over in storage or it's over somewhere else in an office away from everybody where they're just monitoring results and submitting things to CMS just to check the box. but they're not set up for success in a way that says, we're here to support you. Do they have a budget? Do they have something that allows them not only to just check the box, but to make a meaningful difference in how the organization operates? And then once again, just to Lindsay's point earlier about the conditions of participation, it is a condition of participation to have some form of responsible individual and governing body buy-in for our quality practices and making sure that they understand that they have that responsibility to make sure that our quality policies and practices are administered in a safe and effective manner. So what does this look like, though, in practice? It's great to say that we want an engaged board, we want an engaged senior team, and we want to allocate resources effectively. Really, what this comes down to is, do we have decision rights in the right place? When we think about how we set up a budget or we set up organization departments to go after certain financial metrics, essentially it's the same thing for the quality side. Are we setting up metrics and key performance indicators for them in terms of quality, engagement, and operational performance improvement metrics in which they can control? Are we driving the decision rights down to the clinical and operational leaders? Are they things that they can effectively change? If we're looking at hand hygiene performance or other process-driven measures rather than outcome-driven measures, are they things that actually result in something that's going to make a difference? Do we have time set aside to educate our managers on the business of healthcare, not just from the financial aspect of it, but are we sitting down with leaders and managers talking to them about the importance of quality outcomes and how their performance impacts us from a regulatory standpoint, from a safety and patient perception standpoint? These conversations can often be done in tandem with just the financial conversations around the budget or variance conversations. And do we have conversations? Many hospitals that really have a focus on hospital quality also have a focus on getting together to talk about operations, daily huddles, safety calls, whatever works for their organization, understanding resources are thin and limited. Staffing and the ability to staff huddles appropriately is going to look different for various hospitals. But do we have a way where we can get everybody together for a quick touch base to talk about operations and quality in a proactive way, rather than just responding when an event occurs and we're doing a root cause analysis after the fact? Are we looking for leading indicators that may say something's going on that we need to look further into? And then do we have performance measures in which we're looking at quality from a strategic KPI-driven fashion? Is there an organizational goal for quality? Do we look at, we want to reduce falls by a certain percent, or we want to have this level of HCAP scores, or we want our recommend the hospital score to be X, or sepsis is going to be X? What does that look like for the various departments? One thing we often hear for a quality metric in some of our med-surg units is, barcode scanning compliance, and we're posting that and having conversations about that on a reoccurring basis to make sure that we're promoting the highest possible care for our patients and our community. And then are we effectively recognizing our employees for what they're doing and rewarding our system for when it acts in a way that we want it to? Very often, one of the things we talk about is, are we incentivizing providers in some form for quality incentives, but do we also recognize and incentivize employees when they go above and beyond the quality domain? Whether it's an employee spotlight, some kind of good catch award, whatever it may be, do we have a mechanism in place to recognize when people are excelling in the quality space? And really, this is just a look at what we feel are key roles and responsibilities as you work down the line. Our board of directors, board of trustees ultimately are accountable for the quality program as a whole. Do we have a functional setup? A senior leader team make sure it functions correctly? Are we involving? Very often we find that the quality program and the med exec committee or the medical staff aren't necessarily involved. We feel quality is important, but we just loop med staff in. We don't necessarily look for their input. We don't look to them for guidance. But understanding that provider alignment, if we go back to that transition framework, is really critical for kind of moving forward to a future in population-based healthcare. We want medical exec and medical staff guidance on quality procedures, best practices. What does it look like to be an evidence-based organization? We utilize our quality committee to effectively monitor progress, We have our departments and reporting entities to monitor improvement and to drive that forward. And then other committees, such as the safety committee or P&T, various committees focused on compliance, organization, making sure that, not everything needs to be ran through quality, but there are smaller levels of expertise in which patient experience can go and handle things, or it's a root cause analysis by one committee. Do we have a design that fully supports quality as a whole, not just necessarily one person looking at things from a regulatory point of view? And then when we think about our quality plans and the way that our quality plans are designed and the quality program set up, we know that a hospital must develop, implement, and maintain an ongoing data-driven program, and that the governing body must ensure that this really reflects the complexity of the organization. And we've got to prove this. Oftentimes, where we see a lot of organizations get hung up is in this reflecting the complexity of the organization and the scope of services offered by the organization. Quality is much more than just the little things about writing a plan. It is, do we have a quality program that monitors not only the departments that serve our patients, but the contractors or the third party that work within our hospital? Do we monitor those for quality and compliance? And do we have KPIs around that? It's about making sure we're intentional with how we measure and monitor and track data to keep patients safe and keep them engaged in their healthcare. So these 4 characteristics of a strong quality plan, we would argue, are also just strong characteristics of a well-running hospital. Do we have a process in place that is systematic and it includes leadership accountability and resources to effectively guide our desired results? Do we have a quality director that is supported in the organization with resources via a committee or other resources that can drive the program forward? Use of data and measurable outcomes. You manage what you measure, and if you're not measuring quality performance, then is it something that you can effectively monitor and drive forward and see sustained improvement? Oftentimes, if we're reviewing quality plans, one of the questions we ask is, do you go back and do an evaluation of effectiveness? Did you meet the desired results that you set in your quality plan? If you're not, there's an opportunity to say, okay, let's look at 2024's performance and 2025's performance, and what can we do in 2026 to either achieve those goals or pivot to something else? And then, do we have some focus on efficiency? Are we doing rapid process improvement cycles, whether it's PDSA or some kind of other performance improvement initiative? Are we continually focusing on being adaptable and learning from opportunities that are presented to us? When we think about an effective quality committee, do we have obviously the quality director, chief quality officer, whatever that may be, CEO, CNO, CMO, ED director, but also equally important, are we involving a board member, members of the finance team, the CFO, the revenue cycle director, and representatives from key departments? We also ask often, do we have members from frontline staff that are able to come to our quality committee and speak on things that they're working on, recent process improvement events that they've completed or projects they're working on, to give them an ability to talk to others, speak up the chain of command, and really share things that are being done on the front lines to improve patient experience, patient safety, reduce risk, and ultimately improve clinical outcomes. And what does this look like for the departments? We have a phrase that we use when we think about financial reporting for our hospitals called management accounting. Essentially, it's the same thing for our departments on the quality side. Are we meeting with our department leaders on a routine and regular basis to have a conversation with them around their quality metrics, just in the same way that we would their budget toward revenue and expenses? Do they have key metrics that they want to focus on as a department? What are the goals for those? How are we going to compare? What are the metrics that we're comparing against? And are there nationally known standards for those comparisons? And then more importantly, what are we doing not only to change the process or achieve the desired result, but what are we doing to sustain the desired result once we've gotten it? Many times, and I'm sure many of you have felt this way, we get to a certain point in sustainment where it's just green all the time, but we just leave it on because it's the easiest thing to do and not necessarily looking for the next metric to select. So do we have ongoing conversations with our leaders about quality and quality improvement? So this leads us now to kind of another polling question. What is the current focus of your organization's quality program?
Thank you, Cameron. So polling question up, if you would mind helping participate and get some answers, I'd appreciate it. So what is the current focus of your organization's quality program? I'll leave this up for a couple more seconds, make sure we get everybody's vote, and then I'll share those results with you both. All right, one more time, just what is the current focus of your organization's quality program? Regulatory maintenance, accreditation, improving patient outcomes, patient experience, population health, or other? All right, I'm gonna go ahead and share those results now. Thank you, everybody.
All right, thanks everybody. So luckily, it varies across organizations, but luckily improving patient outcomes is something that we genuinely always want to see in quality plans or as a focus for quality programs. Improving patient outcomes generally means that we're going to improve the experience. We're going to be focusing on population health. And hopefully along the lines, we're also maintaining some form of regulatory accreditation as we look at that. But ultimately, the focus of our quality program should be on what can we do to improve patient outcomes. And then the last, really one of the, I'd argue probably the biggest pillar is measurement. What are we doing to effectively monitor performance? And are we benchmarking and comparing ourselves to where we were last year, last month, and how do we compare against others? Do we have an organizational dashboard that we post in an area that is visible for others to see, whether it's in a break room, out in some public hallway with, it's HIPAA compliant in a HIPAA compliant fashion? But what are we doing to not only track data, but share this data and the results with our organization? Do we send our quality dashboard to all frontline staff? Is there an email that goes out, a SharePoint site that they can go and access this if they want to review it? And do we have some form of leadership talking about this in a meaningful way that engages patients so they know how their work directly impacts the outcomes that we see in these scorecards? So how do we effectively optimize all this, and what does it look like to integrate quality? As I said, it's sharing and educating all levels of staff, whether it's our providers, our board, frontline staff, and when I say frontline staff, it's dietary, it's EVS, it's all levels of staff, it's maintenance, and how their work impacts the organization's overall quality program and impacts our perception in the community, our stance in the community. Do we have a board member, a hospital administrator, medical staff chairperson who has reviewed our quality plan and agrees with it and signs off on it and sees themselves as a champion of quality within the organization and feels like this is something that the organization can stand behind? Do we effectively utilize PDSA methodologies, Lean, DMAIC, whatever methodology it may be? Have we taught our organization or provided training to members of our organization on how to effectively hardwire these methodologies for improvement? Is it some kind of Toyota management system in which all levels of the organization understand to a certain degree what process improvement looks like, and they can take it upon themselves to implement small daily changes for improvement? And then more importantly, are we making sure that the data is shared and measured and analyzed effectively? And I know this can look different depending on the organization. Oftentimes, while it's one of the most important things, it can be one of the hardest things to get. Does our EMR, do our systems allow us to effectively track and monitor data? Did we just go through an EMR conversion and now historical data that we had is gone? Or these things don't necessarily talk, these two systems don't talk between the ED or the clinic or our med surg unit. So there are many things that can influence the effectiveness of a quality program. Culture, ethics, organizational priorities at the time. It's much harder to focus on quality if we're trying just to make payroll. That is an understood reality of where we're at, but still an organizational imperative to make sure we're maintaining quality and accreditation as well. Because the worst thing to have happen if you're in a financially difficult position is to get a letter of immediate jeopardy as well. So those two things don't necessarily stack up as a recipe for success. To what degree are governing bodies and administrative and management and providers aware of quality? Oftentimes, a board is very aware of the financial responsibility and financial obligations that they have towards an organization, but they don't necessarily understand what it means to be also accountable to quality and patient experience and patient safety. So is there education that you can provide them to make sure that they're aware of the duality of their role? Do we have an effective structure and system in place? Once again, is quality just more than a person with a binder who's making sure that we're maintaining accreditation? Or do they have a system in place, whether it's just an N of one, but do they have other people they can go to help drive an effective quality program? Do we have the effective equipment, capital, the resources, as Lindsay mentioned earlier, human capital, actual equipment capital, physical capital, to make sure quality effectively moves forward in a way that it is both beneficial to our organization and our patients without being a strain on our budget? And then financial budget and resources, as we talked about, we know that's a reality right now. So do we have the ability to effectively budget for quality and give it the attention that it deserves? All of these are going to impact the effectiveness of your program. But as long as we have some form of leadership commitment, we have our infrastructure in place that can effectively grow quality and improve outcomes, and we have a measurement system of some form, those three things really can get us most of the way there. And then this brings us to our last polling question. So what do you find to be the largest barrier to sustaining quality improvement in your organization?
Thank you, Cameron. I'll leave this up a little bit longer for everybody to vote. We do have lots of questions coming in. So on that note, please don't forget, go ahead and put those in the control panel at any time. And when the presentation is over here, we will get to those questions for you. While everybody's voting, I do want to let you know there is a recording. I've had that question come up. There is recording. You'll get it automatically. And if you're interested in the slides, please make sure you reach out to the Stroudwater team. I'm sure that they will be happy to get those to you. Or you can reach out to me and I'll make sure they have your request. Right, I will go ahead and share those results now.
All right, so 52% said that the largest barrier to sustaining quality improvement is engaging stakeholders which is what we tend to hear very often, and most often we can get the data, we know how to write a SMART goal, or we know how to write an action plan, and we know how to monitor it, but it's just getting people to buy into it tends to be where we get hung up, especially in sustainment. So what does that look like for us moving forward? And I'll turn it back to Lindsay to kind of kick us off with that.
Yeah, so I think that was a great segue into especially the results of that poll, right? It's around engagement. And, you know, we talked about the importance of quality as a strategic imperative. And then Cameron just presented, you know, an effective framework, what that would look like. So how do you do, like, where do you start? And, you know, we think it starts with engagement. And so the psychological safety aspect of engagement is also, you know, part of high reliability organizations. There's the collective mindfulness where everyone basically feels safe giving candid feedback and comfortable reporting problems. William Kahn believed engagement takes place when three basic needs are met. Again, around personal feelings of meaningfulness. So meaning that they feel valued and appreciated, that psychological safety, and availability. So having that physical and mental resources without distractions to engage at work. Next slide. And so what are some outcomes of or favorable outcomes of employee engagement, and what that looks like from both an individual's benefit and an organizational benefit? And I won't go over all of these, but when you look at from an individual benefit for organizations with favorable or high employee engagement, right? There's that higher job satisfaction. In organizational side, you may see improved customer service ratings, and you know there is the linkage between individual satisfaction and the benefits that come out of it from an organizational perspective. Next slide. Oh, is this me?
And
go ahead.
oh, got it. So what does it look like to actually impact engagement from our perspective? One of the questions, again, that we ask, is there a standardized orientation for new hires, new employees? Very often, most organizations have some kind of new employee orientation. But when we're thinking about it from the aspect of quality, do we have somebody from quality that goes and speaks to new employees when they start to say, what does it mean for us to, improve clinical outcomes? What does patient experience our way look like? What does the patient engagement look like? Do we have somebody from quality, not just somebody from the organization who gives the same kind of templated standard canned response, but do we have somebody who's out there talking about quality and what it means for our organization? Start buy-in early. From the second they hit the organization and walk in, start their first day, what does it mean to have a high functioning quality program here? Are we having annual employee engagement surveys, utilizing that to improve satisfaction, address any concerns, identify other opportunities? If people don't feel like they are valued at work or that they are able to provide feedback in a meaningful fashion, they are not going to be as engaged in work that needs to be done. So is there a way, do we have an ongoing annual survey or even biannual to the degree that we can, that measures overall just feeling of belonging, feeling, and just identifies opportunities for improvements for whether it's quality, leadership, or just any other general opportunity to make people feel like this is a place I want to work long term and give my all to. And then do we have some form of leader to employee rounding? Oftentimes this is where we get into the kind of rush of the day. There's 1,000 fires to put out. We're very reactive. But do we have just 5 to 10 minutes to round on a unit, to round with our team and ask them how they're doing? Ask them about what's going on in their world. I'll go back to the example of barcode rounding. If we have some form in which we're monitoring progress, are we walking around and asking people, hey, how's it going? How's the barcode scanning process going? What are some difficulties? Is there anything that you think we could do to make this easier for you in your day? Little things like that go a long way, especially in the quality improvement space, where many people are just left feeling as if it's just a very large thing to tackle as a whole. All of this leading us to what Lindsay kind of mentioned earlier is we want to get beyond engagement to this stage of continuous improvement, continuous sustainment, looking at collective mindfulness, which is where we're looking for and reporting small problems, unsafe conditions, or any risk when they're still easy to fix. Is everybody in the organization thinking about quality in the same way? Are we thinking about safety in the same way? And once we get past engagement and we get people to start thinking about improvement as just this collective thing, then it's easier for us as an organization to move quality forward in a strategic way. So to bring this all home, what leadership commitment for quality is a strategic imperative. Without that, nothing else really moves forward. Do we have an effective infrastructure to support quality and patient experience and safety goals? And do we have a measurement system in place that people can look at and understand and know where they fit into that process and how they can drive improvement on a daily basis? And with that, Cody, I'll turn it back to you.
All right, thank you so much, Cameron. So I'm going to open up for questions. If you want to go ahead and go on to your closing slide, that would be great. All right, so again, there is Lindsay and Cameron's information here. Please feel free to reach out to them for slides, or feel free to reach out to me, and I'll make sure they get those requests. Recording will be coming, so let's launch into these questions. I'm going to go from the order they've come in. There's several. So to kick us off, in questions like the first polling question, how important QI is in the organization strategic plan? When participants gauge importance, do you think they consider if the QI leader is on the organization's leadership team? How often is the QI leader on the leadership team on the same level as the CFO? That was a long question, so if you need me to read it again, let me know.
No, thank you, Cody. That's a great question. I chuckled a little bit because I do feel that this question does come up a lot. I have seen varying degrees of this playing out in rural organizations. Some have the quality person, quality director, manager, whoever that may be, as part of the leadership team. and have that kind of a poor maybe quality performance. So it doesn't necessarily kind of tie back to the overall strategic importance or even the performance of the organization. I do, and Cameron, chime in here, but I do think that if organizations are committing to quality and it is a strategic imperative for your organization and a priority, I would think that either from a reporting structure or even as part of the leadership team, the quality person is as a member. I think it drives
I would
it.
echo Lindsay's opinion. And, you know, we've been asked a question similar to this as well. And I'll just ask it. I'll say it as, you know, does the location of the quality office play does that impact how quality is perceived in terms of strategic importance? To a certain degree, perceptions are reality. You know, the person asking their office for quality was in the basement, or it was well away from everywhere else in the organization. So to Lindsay's point, making sure that that person is engaged or at least has a seat at the table is important. And also, you know, where do you locate them? It places some kind of importance on the overall perception of its importance in the organization.
Thank you. So another question that came in, how to elevate and support CAH QI leader skills. I'm wondering if any states have considered this as a topic of their rural health transformation program funding.
I don't know if it's part of some of the rural transformation funding. I mean, I would think that's a great idea. But I think that there are education opportunities, training, certification programs that are out there to help and elevate the skill sets of quality leaders. States, if you are a critical access hospital and you have access to your state office of rural health through the FLEX program, there is a quality component to that, and that is a great resource, especially for new quality directors, managers, coordinators, whomever, to get access to resources and training and coaching through that as well.
Thank you. Cameron, anything to add before I move on? Okay. All right. So next comment / question. So many of the standard quality metrics are difficult to use in a CAH setting. When falls or med errors are few and far between, our usual methods of data collection are statistically insignificant because of the small numbers. Do you have suggestions?
You want to take this one, Cam?
Yes, that is a good question. And Lindsay, do you have an answer off the top of your head faster than I do? I got to ponder on that.
I was going to say, I think they're all, you know, yes, we recognize that your critical access hospital numbers may be lower, right? I do feel that there are times where the data collection is important for the organization to do. I think that's also a topic that you would bring back to your quality committee and say, hey, you know what, we've been monitoring and reviewing falls for quite some time. Does it make sense that we, you know, and we're at 100%, you know, we have 0 falls in the last like 6 years. Does it make sense to retire that and not, you know, have such a focus on measurement for that? So, you know, I think it's something that you would bring back and really kind of discuss. There are those measures that we have to, from a regulatory reporting requirements, have to measure, have to submit and report on. So I think those continue and will continue to be essential for organizations to focus on.
And I would encourage, to Lindsay's point, whatever conversations with department managers you can have to focus more on the leading indicators rather than outcome driven lagging indicators. We're likely to have more leading indicators that indicate opportunity than maybe it's a fall, which is something that's occurred after the fact. So is conversations with department managers who are doing the work on the front line, they might also have an idea of what can we effectively measure that allows us to look at more data. Good question.
Hey, thank you. Thank you so much. So if you have questions, we do have a little more time. Please feel free to put those in that question panel and we'll be sure to get to them. Those are some really great ones, but I'm sure Lindsay and Cameron are happy to answer more. With that, unless I see any questions come in, I'm going to turn it back to you, Lindsay, Cameron, for any closing remarks.
No, thank you. Thank you, Cody, for having us. We've enjoyed being able to share a little bit more about quality and how it relates to strategy and the overall effectiveness in an organization. So feel free to reach out if you have questions, follow-up questions. We are here as a resource.
Yes, thank you.
Thank you. I did have a couple comments come in. Just great presentation as always from Stroudwater Associates. We appreciate all of your support. I don't see anything else coming in, so I'll go ahead and close this out, but that doesn't mean you can't reach us. Please feel free to reach out to me. I'll put my information in the chat here in 1 second. And you have Lindsay and Cameron's. I know they're happy to answer any questions. As a reminder, you will receive a recording later today, or a recording link later today. You can email that to anyone else, revisit it, share it with someone on your team, however you feel useful. I know there is great information. Also, there is a short survey. Please, please, as a personal favor to me, just take 1 minute to fill those out. I really do read every one of them, and it helps me keep these sessions focused on what rural leaders are dealing with right now. And if you're looking for more resources, tools, or upcoming educational sessions, you can always find those at nrhasc.com. And of course, you're always welcome to reach out to me. And thank you finally to Stroudwater Associates for your founding partnership. We could not do this without you, and your support for rural healthcare helps make sessions like today possible. And of course, our upcoming conference in San Diego that we hope to all see you at. All right, I haven't seen anything else come in except for some kudos. With that, I'll let everyone go. We hope to see you again soon. Have a wonderful, safe Tuesday. Bye all.
Thank you.